You on 8? 2 on 8. Okay, you're clear. Stand by for your base.
Welcome to EMS Cast, where we provide high-level education for you, the providers on the streets. I'm your host, Ross Orpit, and today we have back with us our emergency pharmacist, Lance Ray, to talk about an interesting study I came across the other day. And we're going to use this as kind of an opportunity to review benzodiazepines and their utility in seizures. We actually did a seizure episode and covered a lot of this in a prior episode. So I recommend you go check that out because that was also awesome. But today we're going to review some of that. And then we're going to talk about this study entitled The Real World Use of Midazolam and Outcomes with Out-of-Hospital Treatment of Status Epilepticus in the US. This was published in Neurology in 2022. So Lance, welcome back to the show.
Ross, thanks for having me. Always good to be back on the pod. And it's glad you brought up this important study that came out a bit ago. It's going to be good to talk about it. And just like you said, I think we'll be able to kind of work around the framework of benzos and various drugs and what we should be doing for status.
Yeah, perfect. So before we get really into the meat of all this, we will just say a disclaimer. We're going to talk a lot about dosages here and specific milligrams of benzodiazepines. Whenever we talk about dosages of medications, this always comes with a disclaimer of, you have to follow your local protocols. You have a medical director who's thought about these protocols and spent time and made best decisions based on your specific scenarios. So know your own protocols and follow those. But we're going to talk about kind of some national guidelines, what they recommend, and then we'll get into the meat of this paper. So we use benzodiazepines often in emergency medicine. And I think first we should probably just kind of start with the review of our benzodiazepines. So let's start there.
Yeah. So before talking about status, we have to discuss benzos as well as maybe we'll cover a few other drugs, but these are really our pivotal agents in treating status. So the American Epilepsy Society, their most recent iteration of the guidelines came out in 2016, and they recommend 3 options as our first-line agents. There's sort of a second set of first-line agents we'll get to later, but these first-line agents are benzos, okay? So we've got midazolam, lorazepam, and diazepam. And the midazolam is the kicker here because it's the only one that's intramuscular. So to back up, I think probably the gold standard for treating status is lorazepam. The reason for this is because it's got a long half-life. It's also highly protein bound. So it's, if you look at drug references and you don't see that it has quite as long as a half-life of, say, diazepam, this kind of protein binding helps it kind of depot, if you will, within the serum and slowly releases into free levels. So this is the classic first-line medication for status. The dose is 4 milligrams IV with the option to repeat times 1 dose. Now, for smaller pediatric patients, the dose is 0.1 mg per kg. Of course, this maxes out at 40 kilos or 4 milligrams IV. Of course, this is the Class A recommendation.
It's interesting that you say Ativan's generally thought of as our go-to benzodiazepine in status seizures, because as we'll get to later in this paper, that actually calls that into question. And it's an interesting point. I'm going to put that on pause, but I just wanted to highlight, we're going to get to that in a second. Okay, so that's lorazepam. Tell us more about midazolam and diazepam.
Yeah, then diazepam. So midazolam, okay, so first it's dosed 10 milligrams as an intramuscular dose, right? So the guidelines, interestingly, don't give an IV option. We'll talk about in the paper, and people are saying, well, I think we give IV a lot, and we do. So the reason for that IM recommendation is probably in part because the half-life is much shorter. It's somewhere between 1 and 4 hours. And the other agents, lorazepam and diazepam, are at least 24 hours half-life. So half-life is shorter. This results in the need for more rapid dosing, and why the status guidelines really don't mention it as an IV option. So it's not technically endorsed in the IV route. There isn't a huge depot effect from midazolam, so it's really equivalent when we use it IV and IM, and somewhat equivalent doses. So the recommended dose again for status is 10 milligrams intramuscularly times 1. The pediatric dosage is a little more unique. For those between 13 and 40 kilos, it's recommended as a fixed dose of 5 milligrams intramuscularly. And below that, we typically give 0.2 milligrams IM for those under 13 kilos.
Okay, interesting. And so when you say that there's not really a depot effect, you mean the rate of absorption intramuscularly and IV is thought to be similar?
It's fast. Not quite as similar. It might take 5 to 10 minutes for the IM to work, but that's pretty quick for an IM. So it doesn't have any long-term depot effect. It's thought to be almost equivalent. Obviously, you're going to get much faster levels with an IV bolus, but the intramuscular route doesn't lag too far behind.
Right. So what you're saying is it doesn't take longer to metabolize. So the half-lives are essentially similar intramuscular.
Yep.
Okay. So it'll go away as fast as an IV will go away, but IV may affect you faster.
Right. And that's really, I think, yes, it's a first line agent, but it's something to be aware of is that it wears off much quicker than the others. You would just have to keep an eye out on your patient, knowing that benzo is going to wear off quite a bit sooner than the others.
What about lorazepam intramuscular? You didn't talk about that at all.
Yeah, good point. So that's the one benzo that I should say, when we're talking about midazolam and IV, midazolam can be given in all routes, IV, IM, intranasal, as we'll talk about a lot more later. But lorazepam should be given IV and it should not be given intramuscularly because this does have a depot effect and it takes a lot longer for it to work. So we should not be using lorazepam intramuscularly.
Gotcha. All right. What about diazepam?
So diazepam has a long half-life, a little bit longer than lorazepam. It's less desirable probably than lorazepam from many perspectives. The dose is the same as midazolam, but it's IV. So it's 10 milligrams IV times 1. And like lorazepam, there's an option to repeat that dose. We probably won't talk about diazepam a lot from here on. It's less desirable for a few reasons. Early studies, 2001, I believe, comparing it to lorazepam and then placebo, believe it or not, it showed to be less effective compared to lorazepam.
Okay. So in seizures, diazepam has maybe been studied against lorazepam and is questionably not as effective as lorazepam. It classically or old school was given to parents, for a rectal rescue medication if their kid had a seizure disorder, but we're not seeing as much of that anymore either, are we?
Right. There's some literature recently that compared intranasal midazolam, a route that we'll talk about a lot here, compared to rectal diazepam, right? So Diastat was a brand name diazepam product where it was popular to prescribe that for sort of breakthrough or seizures that parents could use at home. It was found that intranasal midazolam was as effective as rectal diazepam and a lot easier to administer for obvious reasons.
Okay. Can you give diazepam intranasally?
I don't know of any literature to support that. And it's probably reminds me of lorazepam. It's a very lipid formulation. If you've ever drawn up a vial of lorazepam, the same with diazepam, they have to be dissolved in the solvent into a solvent. Actually, lorazepam's polyethylene glycol solvent, which we worry about more in the ICU and buildup of this toxic alcohol. So they're very viscous and they're just not absorbed well or not amenable to intranasal use for one reason or another.
Huh, interesting.
Yeah.
Okay, where are we headed next?
We'll talk about lorazepam, sort of gold standard. I mean, so we've got three first line agents. It has a longer duration, but we use midazolam IV a lot, right? I mean, it's just built into several protocols. We give midazolam IV, even though it's technically only recommended to give intramuscularly. So midazolam's fine to give intravenously. There's literature to support this, especially if you have a line and it's your only benzo option. As I mentioned, lorazepam's been on back order for a while. Lorazepam also has to be refrigerated, and that's a logistical and operational concern, both in the hospital, but especially pre-hospital. So that really precludes its high utilization in addition to its back order status recently. So we really default to midazolam. It's really our workhorse. We use it both IV and IM.
Are the doses differently between the two?
The doses are considered to be the same. Where we get to intranasal midazolam is where there might be a little less absorption, but we're still talking 70 or 80% absorption compared to the other two.
Okay. So really good absorption, IV and intramuscular, maybe a little less in the range of 70 to 80% when you're giving it intranasally. So we might end up recommending larger doses intranasally. Right.
Exactly. And again, just to reemphasize, the half-life is a lot shorter with midazolam. And so because of that, I think it works to our benefit is that we're not as concerned with dose stacking, and we should be comfortable giving solid doses, guideline recommended doses of midazolam, like 10 milligrams IM, and we could give 10 milligrams IV too.
Okay. I guess one of the other things we should maybe mention with the challenges behind lorazepam pre-hospitally too is that it needs to be refrigerated.
Yeah, exactly. It needs to be refrigerated. Once it's taken out of the refrigerator, sometimes if you work in the hospital, you might see a sticker that we put on it, sort of like a dollar store sticker that has an expiration date. So once it's taken out of the refrigerator, it's only good for 60 days.
Okay. Okay. So now we've kind of reviewed our three main benzodiazepine options. We've talked about how these are going to be our first line options. We've talked about some differences between the twos. Why don't we briefly touch about what if we give one of these drugs via one of these routes and it's just not working? What do we have next?
So there's, as I mentioned, a second set of first line agents. Well, before we go to our true second line agents that are all intravenous and IV piggyback or infusion. So there's a second set of first line agents that the guidelines offer. And it's IV phenobarbital at 15 milligrams per kilo. That's a level A. And the other two are slightly recommended less as level B recommendations. This is per-rectal diazepam and intranasal midazolam. Now, the caveat with this intranasal midazolam, there was actually 3 studies. There's been a few more studies since the guidelines. Of course, they came out in 2016, showing that these were actually superior to rectal diazepam, as I mentioned a little bit ago. And other data shows that intranasal midazolam also works quick, a little bit slower than intramuscular, which is a little bit slower than intravenous. It's still been shown to terminate seizures within 5 to 10 minutes.
And so you mentioned fixed dosing for pediatric patients that are greater than 13 kilos. So 13 to 40 kilos, we're going to give a fixed dosing of 5 milligrams for midazolam. Above 40 kilos, the recommended fixed dose is 10 milligrams of midazolam. And then below 13 kilos, talk to me about that again.
Yeah, so below 13 kilos, few studies out there have showed that 0.1 mg per kg is probably not enough, and that 0.2 milligrams per kilogram is probably the right dose.
And then I've read some too about some of the medication getting lost in the atomizer itself. Do we need to worry about that?
Yeah, that's a great point. So it's important to add an extra 0.1 cc's or 0.1 milliliters of your agent, because there's that hub and that space that fills up the atomizer, similar to an intramuscular, pull up a drug and then add an IM syringe. That needle space is 0.1 cc's. So it's important to add that. We've built that into some of our local references, at least.
Interesting. So if you're going to be giving anything intranasally, whatever medication you're giving in, you might want to think about just drawing up just 0.1 ml extra, because that's going to get lost in that atomizer.
Right. And where that really matters is, say, our 0 to 10 kilo patients, right? That's where like that 0.1 milliliter of medication is going to make a difference. So in the really small kiddos.
Okay. And just as a reference, a 12-month-old infant is 10 kilograms. So where you really got to worry about this then is the less than 1-year-old. What about neonates? Is there anything special about neonates?
Yeah, I'm glad you bring that up. So that's tricky. It's been shown that our GABA receptors, which is what our benzodiazepines work on, it's our primary inhibitory neurotransmitter in adults, is probably flipped in neonates, and it somehow ends up being excitatory in this population. Well, this puts our first line GABA agents, our benzodiazepines, on their head. We don't really know what to do with this. I don't have really good recommendations on this. It might be because I'm not trained formally in pediatrics, but what is a result of this is that phenobarb ends up being our longtime first agent. Now, phenobarb still works on GABA, works in a different way. It has unique mechanisms. And also, like if you've ever heard of penobarbital in the ICU, it works on decreasing sort of metabolism of the brain too, which can help seizures and sometimes the underlying etiology kind of help calm the brain down.
Wow, that's crazy. So unfortunately, to my knowledge, and maybe there's some systems out there, I don't know of anyone who's carrying phenobarbital on the ambulance. And I don't know if there's another option other than benzos. So what do we do in that case?
You know, I don't have a good recommendation there either, Ross. I would say, obviously, quick transport. In the pre-hospital setting, short-acting benzos like midazolam is still generally thought of as safe and better than nothing. Again, the midazolam is short-acting, so if there's some chance that this might harm or cause more excitatory action in the brain, or maybe increase seizures, which the evidence is pretty frail showing that. Midazolam is going to be your best bet because it's short acting. If you're doing any harm, which we don't know for sure, it's going to be short lasting. And once we get to the hospital and the ED, we can start loading phenobarb or phenytoin. Of note, our primary sort of second line agent that we end up using in the ED a lot is levetiracetam or Keppra. And levetiracetam was shown to be inferior in several pediatric studies compared to phenobarb and phenytoin. So that's worth noting. There's something definitely that's working different mechanisms of seizures, if you will, in pediatrics. It's good to be aware of, at least.
Yeah, interesting, because levetiracetam has been shown to be just as effective as those medications in the adult population.
Yeah,
so.
And the reason that we jump to it first is really for some of those logistical and operational reasons. Phenytoin, which is another first-line agent, same as phosphatidylcholine. We can talk about that if you want. But both of these, as well as valproic acid, in addition to Keppra, are sort of our second-line agents, all with equal recommendations. Keppra, however, is the only one that's really available in our Pyxis machines, in IV piggybacks or IV push, safe to give, whereas phenytoin and valproic acid kind of have different regulatory barriers around them that inhibit them getting, that we have to store them in the central pharmacy, and it's hard to get them up custom-made IV piggyback.
Okay. I guess we should, before we're about to jump into the paper, but quickly, let's just review the guidelines on status. Our last episode went into this in great detail, so if you want more detail on that, you can reference that. But real quick for me, just go through the guidelines on how we should be recognizing and treating status.
Yeah, so we've got our 3 first-line options. That's IM midazolam, 10 milligrams, times 1, IV lorazepam, 4 milligrams, and IV diazepam, 10 milligrams, both of those with an option to give a repeat dose.
All right, well, let's jump into this paper then. The real world midazolam use and outcomes with out-of-hospital treatment of status epilepticus in the United States. Tell me about this paper.
Yeah, so this was out of Annals of Emergency Medicine in 2022, as you mentioned earlier, by Guterman and colleagues. And it was a great study of just kind of really just observational. We're just describing what's being done out in the various EMS agencies. They had like 7,000 or more encounters among almost 700 EMS agencies. So the net was cast pretty wide here. First, I'll point out that the abstract says 10 milligrams IM midazolam is the first-line treatment. I think the wording is, I would say, a first-line treatment. But certainly in the pre-hospital perspective, it's really going to be the one that you'll virtually like always have. You probably won't have lorazepam, and you probably won't have diazepam. So it may be kind of the first-line available treatment from a pre-hospital standpoint.
Yeah, advantages like we talked about before with midazolam, it's shorter acting, faster onset, easier storage, and has less of those logistical issues that lorazepam has, given it has to be refrigerated or thrown away after 60 days. And then diazepam is just slow and long acting.
Right.
What was the study specifically looking at?
So the study essentially looks at patterns of how benzodiazepines are given pre-hospital. They did all these different sort of categorical groups of, was 5 milligrams given, was 10 milligrams given. And it was a really interesting overview of sort of real world experience, how pre-hospital providers use benzos in treatment of status.
And they used a data set from ESO, which is one of the largest EMR, electronic medical records for EMS out there. And so it's a specific ESO public data set that they used. And they used a bunch of criteria to pull out of that. One of the criteria to kind of locate the patients they were looking at was the diagnosis of status. And essentially in ESO, you're required to pick from a diagnostic impression, and there's preset impressions. You can't type in your own. And one of those is status. And they chose status seizure, not seizure. Why was that?
Yeah, that's important. And I'll talk about it later. We did a kind of a similar smaller observational look at our facility a few years ago. And it's simple. We just drew like ICD-10 codes, what folks came in and ended up being diagnosed with, and we pulled status. But yeah, it's important to have a working definition of what you're going to use as your sort of entry point in your diagnosis code here. It looked like, although their sensitivity wasn't very high, their specificity, positive predictive value from some previous studies that they'd done, had shown that this was a good code to work with.
The idea was they didn't care if they were missing all of the seizures or even if they caught all of the status seizures, but they wanted to make sure what they were looking at was indeed status.
Right. Having a high specificity there's not very many false positives. So, yep, they were very sure that they caught status.
So this is very much a real world study with all kinds of limitations with risk of bias and unrecognized confounders, but they wanted to compare different routes of midazolam essentially to intramuscular. It seemed like they used that as like guideline recommends intramuscular midazolam. That has been what's studied, but we're giving a lot of intranasal now. So let's compare intramuscular to intranasal. And then let's also compare intramuscular to IV. And let's see how those two groups or those two comparisons shake out. And so everything they looked at was essentially compared to what they felt like was, recommended in the guidelines as the standard initially, which was intramuscular and which has been most studied.
Right. And their primary outcome ended up being administration of rescue meds. So this is kind of like their medication number 2. What did they have to give another one? They also looked, of course, at ventilatory support. Ross, I don't know if you want to talk about how they define that.
Yeah, we should talk about ventilatory support. I think one of the concerns when we're given benzodiazepines, especially when we're given benzodiazepines at the large doses we're talking about with status, and we've talked about how important it is to give appropriate doses, because if you're not giving appropriate doses, your GABA receptors theoretically can become resistant to that. So, but we get concerned. We're given whopping doses. We get concerned about respiratory depression, and we should talk about that because that's important.
So it defines ventilatory support as intubation or a supraglottal airway or positive airway pressure support. And, again, it's important to use this as an outcome. Previous trials focus on this a lot. And one of the earlier landmark studies in CU status in 2001 that compared lorazepam to diazepam to placebo, believe it or not. That's how late we are in the stage of studying status. In 2001, we were comparing it to placebo because that's how much we didn't know. And the placebo group actually had twice the intubation rates as lorazepam or diazepam, like 16% compared to 8%. So it really highlights to me the need to treat with adequate doses. And I think that's one of our main concerns, Ross, right? We get worried that, is a respiratory drive going to decrease these high doses of benzos, but not giving benzos is actually doing more harm. Leaving that patient in status, they're probably less able to protect their airway.
Yeah, what we're saying here is that the seizure itself is causing more respiratory compromise than these large doses of benzos do. So you're safer giving these large doses of benzos than risking them remaining in status.
So let's look at the population here. As I mentioned, there were over 7,000 pre-hospital encounters, all treated with midazolam. About 16% of these were rural. So what they ended up finding was that about 4.1, I should say only 4.1% of their encounters, patients were given 10 milligrams of intramuscular midazolam.
That's why I want to highlight that. That's wild. In this paper, when they looked at 7,000 patients across multiple EMS agencies, only 4% of them got the recommended guideline treatment. 4% of the time, we're treating seizure patients the way that the guidelines recommend we treat them.
Right. And would you be surprised if I told you there's some other literature out there reflecting the same thing? Not as low as 4.1%, but there's other, this isn't just a one-off study. There's other data that support this same phenomenon.
I mean, with that low of percentages, I can't imagine that it's just as providers we're all treating them wrong. I have to worry about that. The protocols are what reflecting this. And so it may be that you're limited by your protocols. Your protocols are recommending lower than guideline recommended doses of benzodiazepine. So again, your hands are tied, but I think that's something we need to talk about because it seems like a problem. Either the guidelines are wrong or all our protocols are wrong. And so we need to come up with a better answer for this.
Yep. And I've seen protocols that have lower doses of 2.5 of midazolam. Then you can repeat another 2.5. Some say you have to call the base before giving more benzos. And there are, like you mentioned at the beginning of the cast, there's reasons for that. These have been thought about, but it's still maybe a sign or a signal that we need to look at these closer.
Yeah, I think more research. I mean, I'm not trying to say that all of the medical directors out there don't know what they're doing and they're all wrong. I'm trying to say them and the national guidelines need to come together and come up with a consensus.
I'll say one of the reassuring things that we mentioned a few minutes ago about the design was their sort of tests for catching all the folks that were in status. Their specificity was high. They weren't missing very many people. And that's reassuring to me, is that we can come up with some diagnosis pathways that catch and identify status early. Because I think that's one of the main concerns is, well, is this status or is it something else?
Yeah, absolutely. Okay. So we're not treating per the guidelines at least in this study on a national level. But what are we doing? What are the doses we're giving, and how did the different doses compare to one another? How effective were they?
They found that they gave, after this initial dose, they gave rescue therapy, which was sort of dose number 2 in 29% of patients. And they found that they only gave ventilatory support per their definition in 6.1% of patients. So the main outcomes here were, of course, the initial route, time to administration. They observed all these. They found that intranasal was given about 20% of the time. IV midazolam was given 45% of the time, and intramuscular was given about 34% of the time. And yes, those do all add up to 100. I checked. But what was interesting was the time to administration. So you may have talked about the Rampart study in your recent podcast. It was a huge, pre-hospital landmark study comparing IM midazolam to IV lorazepam. And of course, we know that it takes longer to get an IV line, to administer an IV benzo compared to just giving it intramuscularly. And that's what they found here too, was that their average time to administration in both the intranasal and intramuscular doses were about 8.5 minutes. And the IV midazolam took about 15 minutes to administer. And it was just so this was about a 6-minute delay from intramuscular and intranasal to giving intravenous agent.
So they looked at the various routes of administration. They found that giving intranasal or intramuscular Versed took on average about 8 minutes to get that done, whereas it took almost double that to get IV. So obviously you have to establish IV access and then give the medication through the IV route. It took a little over 14 minutes to get that. But what were the results? Which route worked better?
We'll start with the IV midazolam. It was associated with about 11% decrease in rescue therapy. So we weren't, the outcomes here, we weren't monitoring cessation of seizure. Obviously, we don't have EEG. So really the surrogate marker here was decrease of the next dose of therapy. That means we assume that the seizure is stopped if we're not giving the rescue therapy. So IV was associated with about 11% decrease in rescue therapy. Intranasal was associated with about 6.5% more rescue therapy. So it went the other direction.
That's one of the big limitations of the study is they're not actually defining yes, no, seizure stopped. So we don't know if, hey, maybe seizure was still ongoing when they got to the hospital, they handed the patient off and the hospital staff redosed the patient. That wouldn't have been counted, and that would have been assumed that maybe the seizure stopped for them, even though it didn't. And so it adds a big limitation to this study, but they're essentially using redosing of benzos or rescue therapy as failure of the initial dose. And they found that when it was given IV, there was less rescue therapy needed, about 11% less rescue therapy needed compared to intramuscular. And then when you compared intramuscular to intranasal, the intranasal route needed much more rescue therapy than the intramuscular route did, or about 6% more, I should say. So if we're going to rank these, which, I'm just going to go out on a limb and do it.
Let's do it. Go for it.
Intranasal worked the least often. Intramuscular worked kind of in the middle. And then IV, even though it took like 6 minutes longer to give the medication, worked the best and required the least amount of rescue therapy.
Right. It's a great way to lay it out, Ross. Thanks. And of course, an important caveat is we don't know what happened once the patient got to the ED or anything else in the hospital therapy. So that's an important limitation. to note. But yeah, if we use these kind of rescue therapy administration as a surrogate marker, then you're absolutely right. IV worked the best, intramuscular worked slightly less, and intranasal less than that.
Interesting. What about the rates of ventilatory support?
Yeah, so there were no change in the ventilatory support rates across routes or doses. However, they found a small increase in likelihood of ventilatory support with each 1 milligram of midazolam given. Each milligram was associated with a 0.4% increase in ventilatory support, which to me is small. Again, since this wasn't an extremely well-controlled trial, it was more descriptive. There's a lot of information we don't have. It would have been fascinating, but unethical to compare this to placebo. But I imagine, based on past data, that our ventilatory support would have been much higher if some of these were not given.
Yeah, that's a pretty small increase. And I think really, there was maybe a trend towards more ventilatory support needed with increasing doses, but it didn't really seem statistically or clinically significant,
You're
honestly. Right. So what I found most interesting, which I alluded to at the beginning of this recording, is that Rampart trial that you talked about, we kind of extrapolated from that, well, IM midazolam, we were able to give that much faster than IV lorazepam. And so speed must matter because IM midazolam worked better than IV lorazepam. And so we just assumed that the difference there was the speed and not necessarily the route or the type of medication we were giving. But when you look at this study, you see that speed actually didn't matter and that actually the route mattered more. That when we gave the IV midazolam, even though it was 6 minutes slower, it worked much better than the intramuscular or intranasal, which makes me wonder, is lorazepam actually a better benzodiazepine for seizures, like we talked about in the beginning? Or was that difference in the Rampart trial, could that have been related to a difference between midazolam and lorazepam? And I think we don't know. I think we need more research.
So one of the questions I had in this study, and I couldn't find it, they did some more complex statistical stuff comparing 5 milligrams and 10 milligrams, but it wasn't clear to me what doses were given among the intranasal, intravenous, and IM respectively. And so we know that they only gave 10 milligrams intramuscularly about 4.1% of the time. But in terms of, rescue therapy administration and how these, how quickly these worked, wasn't clear to me, for example, if you give 10 milligrams intramuscularly, which they didn't do very often, is that going to result in less rescue therapy? And if you give, 2.5 milligrams of IV, that'll probably result in more rescue therapy. It wasn't clear to me. Maybe it's in there and I'm just missing it. But doses matter, obviously. But we know that we didn't dose adequately very often in this trial at all across the board.
Yeah, maybe they included, I didn't see it either in the paper. Maybe they included some of that more detail in their supplemental documents. But I agree, if we're giving 10 milligrams intramuscularly and we're giving 10 milligrams intranasally, but we know that intranasally we're only getting 70 to 80% absorption, then we're really only giving 7 to 8 milligrams intranasally when we give that 10 milligram dose. And so we're not really comparing similar doses at that point, which I think would intranasal be more effective if we just increase the dose? Would it be equally as effective?
Right. I think that's a great point. And I think these doses, especially smaller kid weight-based doses, should be looked at hard. What doses we're giving our intranasal route, because they go as far as to say in their conclusions that intranasal midazolam shouldn't be given, even though it's recommended by the National Association of State EMS Agencies and it's listed as an option in our guidelines and shows some superiority to things like IV lorazepam, depending on the dose used. But I think that's a stretch to say that we shouldn't use intranasal midazolam.
Yeah, I agree. I think intranasal midazolam still worked in this study, right? But I don't know, with regards to that question, is this going to change what you recommend or what you do in the emergency department, the study?
It'll help me keep advocating for high, adequate, guideline recommended doses. And that's what it'll do. And I mentioned we looked at this within our institution a few years ago and found very similar findings that only about, 16, 20% of our patients in status were given adequate doses. Of course, that was with lorazepam, but it's certainly going to have me, even advocate for adequate doses more.
Yeah, That's fair. I think personally, like we talked about, there's a lot of questions, and I think intranasal Versed works. But in my mind, at least with the available evidence we have, and with this, I might favor intramuscular midazolam over intranasal. I know it involves a needle, but if you take the appropriate precautions, and status seizures really aren't flopping everywhere. It's generally tightly rhythmic controlled movements. And so in my mind, the needle danger there is maybe a little overblown. And I think I might favor intramuscular Versed over the intranasal Versed. And I might favor trying to get an IV or an IO as long as it's not going to delay too long, and prefer IV medications.
Yeah. And it begs a question, what are the levels of drugs in these patients? What's the midazolam level, or how much is getting absorbed intranasal? I would bet, and we don't have, every time intranasal midazolam, the few studies that it's been looked at in, these were controlled trials. Patients' heads were tilted back, and we can imagine that the intranasal probably absorbed. We just don't know here. And I'm unsure, not convinced that medication, especially larger doses, 5 or 10 milligrams, it's a cc or 2 cc's. I can't imagine that all of that got in the air and all absorbed in the mucous membranes. I can't imagine some of it didn't drip out.
Mm-hmm. All right. You can give them any route you want as long as you're given the appropriate dose, is what what I'm hearing you say.
I like it. I like it. But I'm with you. I'd probably favor intramuscular from the Rampart trial, but what we know is we're not giving adequate doses, and that's what we really need to advocate for.
Yeah. More studies needed as well. All right. Any other take homes for our listeners?
I think, advocating for those higher doses, reading the guidelines, making sure that you're following those, because it gets a little tricky with the younger, weight-based dosing, but hopefully you have some references at hand you can use to help give the right doses.
Yeah, absolutely. And like we said in the beginning, you have to follow your local protocols, but we'll link to all these resources as well as the guidelines if you want to have a thoughtful discussion with people about are our protocols the right thing to do or not.
Yeah. Thanks for having me, Ross. I appreciate it.
Pleasure as always, Lance.
Compared IV lorazepam to diazepam versus placebo. It's weird how they that's how far along we were with starting, studying seizures, not very far.